Please. Thank you. We're going to have one more break in about another hour-ish. Okay, so we're going to talk about assessment and diagnosis of autism spectrum disorder. So these are the components that you would like to include to do a comprehensive diagnostic evaluation for autism spectrum disorder. We know it can be very difficult to diagnose, so we want to be as thorough as possible. So here are the components that should be included. It's very important to review background information, previous evaluations, any interventions that the child has had and how they have responded to it can be helpful. It's very important to take into consideration language and cultural factors. Has the family just recently moved to the area? Has the child not had exposure to a lot of language? And people at the break talked about other things to consider in addition to trauma. Trauma is a huge thing to consider, and we want to be very, very careful that if a child has experienced trauma, then to be very hesitant about giving a diagnosis until the child has been in a stable placement for an extended period of time. And another thing to consider about language, we see a lot of children that have hearing impairments. I work with a lot of children that have cochlear implants, and people are wondering, do they also meet criteria for autism spectrum disorder? And it's often very difficult to determine. If a child can't hear, they're going to have difficulty obviously learning language. They may have some sensory differences. They may have a lot of symptoms that look very similar to children with autism spectrum disorder. But again, if there's something in the child's background or history that may manifest in a similar way as autism spectrum disorder, take that into consideration and be very, very careful giving an additional diagnosis. It's obviously very important to give a detailed caregiver interview. The caregivers are the people that spend the most time with the child. They know the child best. The ADIR is the gold standard. It's a fabulous, detailed, diagnostic caregiver interview. Unfortunately, it's not used on a regular basis in clinic because it's so incredibly long. It takes 1.5 to 2.5 hours to complete. It's often used in research. So it is still helpful to just go through the DSM criteria and ask the caregiver. It's important to do a medical assessment, a thorough physical exam, and also do a hearing evaluation. It's very important to do direct observation of the child. You can do that using the Adot, which we're going to discuss. You can also do it just using a play-based environment. Everyone should have their own toolkit that might include bubbles and a car, and just some other toys that you can use with the child to try to engage the child and see how they play. It's very important to do a cognitive developmental assessment because then you can look at all the child's symptoms and how they compare to the child's developmental functioning. If a child is 2, but they're functioning at the 18-month-old level, how are their social skills compared to their cognitive level? If everything is similar, that you may be more likely to only consider something like global developmental delay. If their social skills are significantly worse than their cognitive skills, then you're more likely to be concerned about autism spectrum disorder. By 18 months, a child should be enjoying games like peekaboo. So if this child is not, you're more worried about autism. And again, it's very important, don't leave out adaptive functioning because that's often what we care about the most. How is a child functioning in the real world? And that's where you can really make dramatic improvements as well. So there are some autism-specific assessment tools. Here are just a few. There are a lot out there. They're just some commonly used tools that we want to highlight. One is the CARS-2. It's widely used. It's a questionnaire. One thing I like about all of these tools is that they can all be completed by the professional. We've already talked a lot about parent questionnaires, and parents are not trained in autism spectrum disorder. They don't know the specific symptoms to look at. So these tools are all tools that we can use to help us carefully identify symptoms. The CARS-2 is fast. There are 2 levels, a high-functioning version and the regular version. And you can score it yourself based on direct observation and everything that you've learned about the child. This STAT is very helpful. It's an interactive play-based measure to screen for autism spectrum disorder. It's shorter than the ADOS. It takes about 20 minutes. It gives you a lot of very helpful information. It's only been designed to be used for children that are 2, ages 24 to 36 months developmentally. So that's not their chronological age, that's their developmental age. And then the ADOS, we'll talk a lot about the ADOS. It's widely used. It's the gold standard. It's very important to note that these tools are not required to give a diagnosis, and the tools themselves are not sufficient to give a diagnosis. I would never make or not make a diagnosis of autism spectrum disorder just based on the ADOS alone. The ADOS may be elevated for a variety of different reasons. It's really important to consider the child in the context of their history, caregiver report, other assessments, your behavioral observations. Your final diagnostic conclusions are based on all of that information put together and not just on one, even autism-specific assessment tool. That being said, I do love the ADOS. I think that it gives you a lot of information. It's designed to elicit specific symptoms of autism spectrum disorder. It's a gold standard for assessing and diagnosing autism spectrum disorders. It can be used across ages, developmental levels, language skills, so you can pull it out and use it the majority of the time. It's important to note that it's not valid for children that have a nonverbal developmental age under 12 months. So even if a child is 2, but they're functioning under the 12-month age equivalent, the ADOS was not normed to be used in that situation. Also, it says a child must be able to walk independently because in theory they have to walk around the room. I have adapted it, so I don't necessarily, I think that you need to take that into context. You can sit on the floor, you can, it's a semi-structured play-based assessment, so feel free to adapt it as needed. It does take a pretty substantial amount of time, and it gives you a lot of opportunities to see the child. It can take 40 to 60 minutes. And then there are very standardized behavioral observation and coding techniques. We'll briefly cover that. Here's the ADOS 2 testing kit. It's a big giant tub of toys. The kids get very excited about it. Sometimes it's hard to keep them out of the tub of toys. This is a picture of the actual tub that it comes in. You can keep it in this. You can move it into something else. We've tried putting them into toolboxes, these big red toolboxes that are used at a variety of sites, and it's helpful to keep the different tools that you need separated so you can grab them quickly, and also you can kind of block the child so that they can't get at what you don't want them to get at. But it's fun. It's very fun. So the ADOS 2, when it was revised, it now has 5 modules, and the module that you choose depends on expressive language level and age. It added the toddler module, which is for nonverbal kids or single words ages 12 to 30 months. Module 1 is for 31 months and older. Module 2 is for children that consistently use phrase speech. That's consistently, not just one phrase. Module 3 is for fluent children. Module 4 is for verbally fluent adolescents and adults. One thing I want to mention is that you can't score the ADOS if you're using it in children with hearing or vision impairments because a lot of it just isn't valid. I have used it and just administered the parts and used it qualitatively, but don't score it and don't report an actual score. So quiz. This is a harder one. Everyone has A's so far. One group that the ADOS 2 does not address is number 1, typically developing children. Number 2, adults. Number 3, nonverbal adolescents and adults. 4, autism spectrum disorder plus intellectual disability. Okay, 10 seconds. Okay, everyone, yeah, the majority still got it correct. You are right. So, looking at the actual breakdowns, it doesn't specify what to do with nonverbal adolescents and adults. The manual is not clear about what to do. If an adult has intellectual disability, it may be appropriate to use some items from Module 1. This is for people ages 31 months and older. But of course, a lot of those items are not appropriate and might actually feel demeaning to a person. So I would say some people actually pick and choose a few items from different modules, and again, you don't have to score it, you can use it qualitatively. But other than that, the ADOS is very comprehensive and can be used with almost anyone. Here's information about the ADOS 2 scoring. This is just brief information. If you actually want to learn the ADOS, it's important to go to an actual training. It's a couple days of a training provided by WPS or independent training sites. If you're going to use it for research purposes, then the training is even more rigorous. But the ADOS-2 has cutoff scores. A higher score is indicative of more severe symptoms. The item scores are 0 to 3, and there are other scores as well, which are then converted. The ADOS-2, when it was released, it aligns more closely with the DSM-5, so it separates scores into the social communication area and restriction repetitive behaviors, and then those are summed and applied to cutoffs to yield a classification. The toddler module does not give you a classification. It gives you a range of concern, little to no concern, mild to moderate, moderate to severe. For modules 1 through 4, it does give you a specific classification of non-spectrum, autism spectrum, or autism, and there also is a severity rating of symptoms. So these are just some examples of tasks that are in the ADOS Module 1. You don't have to give them in order. You can be flexible. It's nice to start with free play. You have toys on the table, you have toys on the floor, you see how a child naturally interacts, you try to engage with them. It gives you a lot of information. I'm going to give you some specific examples, but it's important to think about these things because these are some things that you can think about doing in your office, even if you're not doing a full ADOS, such as response to name. We saw the clinician on the video do a response to name. In the ADOS, they actually have the clinician try to get the child's attention by calling their name first. Then you move to the parent or the caregiver calling a name. In the video, they immediately move to physical touch. In the ADOS, they see if there's anything else you can say other than their name to get their attention. And then finally, you move to physical touch to see if that helps. Response to joint attention, we're going to talk about that in detail on the next slide. That's another easy, fast thing that you can do in the office. Bubble play is great. A lot of kids like bubbles. Some kids are scared of bubbles. They don't like being touched by the bubbles. So I usually blow them away from the child, and then you can see is the child looking at the bubbles and looking at you. Are they popping them? Are they asking for more? Responsive social smile. Are they smiling at you when you smile at them? Anticipation of a routine. Get the child interested in something and stop and see how they react. Functional and symbolic imitation. Can a child imitate play? Roll a car. Can the child roll a car? Fly a plane. Can the child fly a plane? Pretend to use something that it isn't. So then the ADOS, you use a block and have the block be a car or be a plane. So these are all things that you can practice doing in your office setting. The ADOS has routines, so the Mod 1 has a birthday party, the toddler module has a more age-appropriate bath time routine. Snack is a great way to take a break and to see how a child requests. I usually ask caregivers to bring snacks because so many children have specialized diets. So the ADOS has very specific prompts and presses. So this is just an example of the presses for response to joint attention. You're looking at, does the child follow a shift and gaze alone or follow when accompanied by pointing? There's a hierarchy of presses. It's really important. First, you have to get the child's attention. A lot of people just jump to this without making sure they get the child's attention. If the child's really engaged in something, it's not a good time to do this. So you have to orient the child's body towards face. You try 5 times. You really try to get that child's attention. If not, you continue. Then you exaggerate. Katie, look at that. Katie, look at that. Does she follow your gaze? What is so interesting about that wallpaper over there? If she does not respond, then you add the point. Katie, look at that. Katie, look at that. Up to 2 times. If she still doesn't respond, then you activate the toy and the ADOS. Right now it's this motorized rabbit. A lot of the kids like the rabbit. Again, some kids are scared by the rabbit, and that's diagnostic as well. Okay, so we gave Katie the ADOS-2 toddler module, and she scored in the moderate to severe range of concern. So what does this mean? We've now done our comprehensive diagnostic evaluation. We have collected, we've interviewed the caregiver and gotten a detailed history. We've collected behavior rating forms. We've done a developmental evaluation, the Bailey. We've done a physical exam. We've done our ADOS. So now we have come to the conclusion that Katie does meet criteria as a child with autism spectrum disorder. So how are we going to discuss this diagnosis with the family? It is a very difficult diagnosis to give. It's considered to be a lifelong disorder that's going to pose a lot of challenges and obstacles. And you're giving this information to a caregiver about their child, about the thing that they care most about in the world. So this can be very difficult and devastating news for families. So it's really important to be very careful and aware of how you give this difficult diagnosis. Here's just a general procedure or plan of things that you want to make sure that you cover. It's very helpful to start with the family's presenting concern, join with the family. What are they worried about? Be very family-centered. Obviously, you have your own agenda, but the family is more likely to listen to what you say and follow through with treatments if you're joining with what they're concerned about. Follow their agenda. What do they want to work on? You came in because you are worried that Katie is not talking as much as other children and she is running away in public. How can we understand this behavior and what can we do about it? You review the evaluation process. So you say, we took a very comprehensive look at Katie. We looked at these behavior rating scales and standardized testing and your report and behavioral observations. And then explain the diagnosis. Use specific examples that the family observed. It's very helpful for the family to understand what autism spectrum disorder looks like for their child. It's very helpful to pull things out that you saw during the ADOS or during your play-based interactions. It was very hard for me to get Katie's attention. It was hard for her to engage in back and forth play. Instead of imitating the car rolling, she was tapping the car on the table. These are all things that are consistent and commonly seen in children with autism spectrum disorder. And go through the criteria. We did talk about the DSM-5 criteria, that you do have to have difficulties in both social communication. There are 4 different social communication areas that you look at. A child does have to have difficulties in all of those areas. And a child also has to have accompanying restricted and repetitive behaviors. Again, there are 4 different areas that you look at for restricted and repetitive behaviors. Technically, a child has to have 2 out of the 4 to meet diagnostic criteria for autism spectrum disorder. So you explain the diagnosis, you go through the symptoms, you explain because Katie is showing that constellation of symptoms and those difficulties with social communication and restricted repetitive behaviors, she does meet criteria as having a diagnosis of autism spectrum disorder. Sometimes you have to say, and I am giving that diagnosis today. Pause. Sometimes you want to jump and try to make it all okay. You want to say, it's okay, and let's talk about treatments, and let's talk about all of these other things. But it's important to pause and give the family space to have an emotional response. Let them soak it in. Let them ask questions. Meet the family where they're at. And we're going to talk about that in a little bit more detail. And then also, of course, it is very important to highlight a patient's strengths. You have to give honest information. It's also good to recognize the strengths and to instill hope. And then provide a specific written action plan. It's very emotional for families. Some families stop being able to process or hear anything after they hear the word autism. So if you can give them something written, even just short when they're leaving the office, that will help them. Give them one thing to do, 2 things to do. Go to the school and get ABA behavioral therapy, and then you're gonna have a long detailed report that will come at some point. So communication skills, so that was your plan, all of the things that you want to cover. How do you actually give this difficult diagnosis? It's important to be honest. You can't say what the family wants to hear. Your child has autism, but your child will be fine. They're going to hear the but your child will be fine. The but takes away the autism. Maybe it is both, but you have to be honest about how the child is presenting. Show empathy. Think about where you're sitting in the room. Pull your chair closer. Make sure you have tissues. You have to have tissues. Maintain eye contact, especially if you're using an interpreter. A lot of people get stuck on talking to the interpreter, and the interpreter is talking to the family. It's really important to maintain eye contact and connect with the family. Make it family-centered. We have so much information we want to cover. It's easy to fall into that trap that you're talking, and you're dominating the conversation. Respect the family's questions. Respect their concerns. If they want to jump and go out of order, let them go out of order. It's very important to ask and understand the family's perception. Use open-ended questions to understand their thoughts and feelings. A good question to ask after you give the diagnosis is, what do you know about autism? You'll get a variety of different answers, and the rest of your feedback will be different depending on what they know. It happens less often now, but I have had families say, what is autism? So your feedback is going to be very, very different compared to a family that says, yes, I know all about autism spectrum disorder. I have looked up every single symptom, and I know that Katie does not have it. And you're like, okay, what do we do from here? And it's very easy then to fall into that trap where you feel like you're debating and you're arguing and you're saying, no, she didn't have good eye contact. And the family's saying, well, yes, she does. And that's not helpful for anyone. So if you feel that you're starting to debate or argue, then stop and step back and try to join with the family. You can ask them, what would it mean if she has autism? What would it mean if she doesn't have autism spectrum disorder? What are you hoping to work on? You can join with the family and focus on we all have the same goal. We all want what's best for Katie. We all want to figure out what we can do to help improve her functioning. We're worried about her language. We're worried about her behavior. Let's focus on what we can do to help with that. Respect religious, spiritual, cultural needs. It's very important to think about the child in context, and you don't need to challenge other people's religious or cultural beliefs. I've had families say, well, I just moved here from, this particular family was from India. And they said, well, in India, my child was fine, so autism spectrum disorder is a United States diagnosis. We're going to move back to India, and my child will be fine. And you can talk more about that. What was different in India where they were living and here? Here, the child was expected to sit in a chair for a long period of time at school. They had more family support in India. They had different expectations. There wasn't as much sensory overload where they lived. So there may have been a lot of contributing factors that help the child function better and look better. So you can try to target those differences to try to see what helps the child and what works with the child. One thing that's really, really, really important, and you should always do, is relieve guilt. A lot of families will bring this up on their own. A lot of moms will say, is this because I let my child watch too much TV when they were 1? Is this because I was depressed when I was pregnant or right after I gave birth? And it's really helpful for families to hear, you did not cause this. We are still learning about what does cause autism spectrum disorder. We know it's not caused by parenting. There's nothing that you did or did not do to cause autism spectrum disorder. Now that we know that your child has this, there are things that we can do to help, but it's really important to relieve that guilt. And parents will often cry, so have a lot of tissues. So how to deliver a difficult diagnosis? It's important to practice. It's not a one-size-fits-all. We find role-playing very, very helpful. It feels a little weird and awkward, but it does help when you're actually doing it. So you can practice with colleagues, practice different scenarios where the family doesn't believe you. What do you do in that situation? Where the child is acting up behaviorally. This happens all the time, and you're trying to have a good, detailed conversation with the family, and the child is tired. The child is melting down. You find yourself blocking the door and trying to talk to the family at the same time, and it's not working. So you might have to have the family come back at a different time, or give information over the telephone, or have someone step out with the child, or have extra toys to use at the end of the evaluation that are new and novel to keep the child engaged. It's difficult and it's uncomfortable, so you have to be comfortable giving the family space to express emotions and to feel sad or mad or however they want to feel. Speak in clear, understandable language. Some families have very detailed, complex questions. They want more sophisticated information. Other families need just very basic, clear, concrete information. So you really have to meet the family where they're at and understand what they need at that moment. Use appropriate body language and tone of voice. Don't try to smile just to make it all okay. Be very conscious of where you are in relation to the family. And you're giving a lot of expertise. You're giving all of this information, but besides expertise, your presence is the most important gift that you can offer. Okay, we're going to move on to a different topic.
Great. So I'm going to talk now a little bit about prevalence and etiology. But before I do that, I just wanted to say that if I had seen Katie in my office and we had talked about how do we apply the diagnostic criteria, so she definitely meets diagnostic criteria for autism spectrum disorder. Do we think she needs level 1, level 2, or level 3 support for social communication and social interaction? It's very hard to answer that. I just wanted to make the point that the folks who developed the current criteria had very good intentions, but applying this in practice has been really challenging. But I would probably say level 2 support for social communication and interaction, as well as behavior. Maybe it's level 3, but I'm not, I think she was doing some functional skills. So, and then we do want to make a comment about cognitive and language functions. So she has both cognitive and language delay, and so that should be noted in the diagnostic report. And we haven't identified any other medical conditions yet. All right. So any questions about that? All right. So I wanted to talk now a little bit about prevalence and etiology. And the prevalence has really been increasing dramatically really since the 1960s. And currently it's listed as 1 out of 59. But when I started in the field back in the 1990s, it was 1 out of 1,000. So it's really increased dramatically and even increased tenfold in the last 15 years. Well, what is the reason for that? That's one of the common questions that I get from parents is why is everyone being diagnosed with autism? What's going on? The increased prevalence or number of children with the diagnosis at any one point in time is increased primarily because we're doing a better job of finding these kids. We're diagnosing them more accurately and earlier. So the numbers are increased at any point in time because we're diagnosing younger kids than we used to. Additionally, there are several systems factors that have driven an increase in diagnosis, and specifically that's the availability of more specialized services, both in early intervention and in school-based educational services. So having a diagnosis allows access to more specialized therapy. There's also better public awareness. Casey mentioned, and for myself as well, and Beth, we were talking last night, it's very uncommon for us to get a family to come in and say, what is autism? But at the start of my career, almost every feedback had to start with just explaining what it was. So that's really changed our landscape. The question remains, is the incidence, the number of new cases at each year increasing? And that's harder to answer. We do know that some of the increase in diagnosis really is just being more accurate. And so these data from California's educational district show that as increase in autism diagnosis went up over time, there was a decrease in both learning disability and mental retardation, now known as intellectual disability. So these kids were always there. They were just being called something else before. And how common is autism spectrum disorder? Well, we've talked about it being 1 out of 59, but it's important to understand that it's much more common in boys than girls. Why is that? We think there are a couple of different reasons. One is that there are some genetic differences that may relate to hormones as well as genetics with difference in X and Y chromosomes that make boys more vulnerable to autism spectrum disorder. But like in many conditions, there is also underdiagnosis of girls. They present differently. Girls who are diagnosed have a more severe phenotype on average than boys, but that's because we're not doing a good job identifying higher functioning girls. They tend to have better language and play skills than clinicians are used to seeing. So there have been a lot of efforts to really study this further and think about what are we doing with our diagnostic evaluations. So these numbers may shift in the next few years. Autism is also increased in siblings. And so if a child has an older sibling with autism, they have a 5 to 10% increased risk of having autism as well. And there's also a higher risk of what's called the broader autism phenotype. So in families who have a child with autism, there are also higher rates of other related conditions. For example, Katie had a brother with speech delay. So language delays, other kinds of mental health conditions, ADHD, you'll hear a lot about that this afternoon. These can also be seen in family members at higher rates. And interestingly, there is some protective factor where female siblings of a child with autism have a little bit of a lower recurrence risk rate. So the main cause of autism is genetic. It's highly heritable. We think about 90% of the etiology can be explained by genetics. And this can occur in a couple of different ways. Most people with autism, the thinking is that it's caused by copy number variants or small genetic changes across any of hundreds of genes that are involved in early brain development. There are also a number of genetic syndromes that are typically caused by larger, more kind of severe genetic mutations that have higher rates of autism. We heard already about tuberous sclerosis having a higher risk. Other conditions like Fragile X as well can have a higher rate of autism. But the underlying etiology, regardless of which type of genetic disorder is causing autism, is really abnormalities in neural connectivity, in the connections between brain cells. And there are a number of different genes involved that relate to synaptic function as well as gene expression in these different genes and regulation of these different genes that regulate certain kinds of brain development processes. And abnormalities in any of these can be related to autism. So it's very complex, and there's no one gene that causes autism, which is what we thought years ago we were going to find. Genetics isn't all of it, though. We know that environment, we've already had a number of questions about trauma and caretaking and how that can influence a child's development. So environment is very important as well, and environment can affect your gene expression. So both are important. Now, we had a question earlier that was looking forward a bit to this slide. We have data from a number of different types of research that look at early brain development that do document abnormalities in early brain development in children with autism. So we have earlier studies from autopsies looking at the brains of people with autism and not autism who had passed away, and also a number of animal model studies that show abnormalities in the limbic structures, the cerebellum, and the frontal lobes. And what's interesting is if you think about some of the symptoms of autism, this really makes sense. We're seeing problems with social functioning and integration of skills, combining different aspects of communication, and problems with attention and impulse control. We also have evidence from several different types of studies that show that there's an abnormality in these early brain processes, including autophagy, killing of your own brain cells, and pruning, modifying the different structures on the neurons. And abnormalities in those processes seem to be occurring in individuals with autism, and that's been diagnosed in studies of looking at actual brain cell functioning, both in people with autism as well as in mouse models of autism. And then we also have evidence that there's early excess brain cells because this process isn't happening well, and that's reflected by overgrowth and as manifested by head circumference in MRI studies of young kids with autism. There seems to be an acceleration in brain growth in the first few years of life that then normalizes, so many individuals with autism don't have large heads when they're older. About 25% do, so it's a little higher than the typical population. And just to look a little further, this slide shows some data from a really interesting study. Children with autism, or the brains of children with autism in autopsy studies, show excess spines on the dendrites. So see those little bubbles on the left? There are too many there, so those haven't been pruned off appropriately. And there's a protein called mTOR that seems to regulate this process. And if you have an excess of mTOR, for example, in tuberous sclerosis, you will manifest these kind of findings. And so in a mouse model where they bred a mouse to have excess mTOR function, they show these abnormalities. And when they treated the mice with rapamycin, which inhibits mTOR, it actually normalized. So it's really interesting, and it's helping us understand a little more. This is not at all translating to a treatment right now. It's all research-based, but it's helping us understand that, yes, there's differences in early brain development. What's very exciting is that by modifying the environment, by changing the child's environment, by exposing them to certain kinds of behavioral early interventions, we can actually change some of this functioning. So I mentioned environment, and there's a number of epidemiologic studies that show abnormalities, that show associations between different kinds of environmental exposures and the rates of autism diagnosis. None of these has been proven to be causal. They're just associations. Prematurity is one, as was mentioned. So we do see higher rates of autism in preemies. Prenatal infections, including CMV and rubella. Anybody seen that? No, probably not many. Those, yeah. Older maternal and paternal age, and this is a very concern to many of our parents and is thought to possibly be another cause that we're seeing, because the average age of parenting in our country has increased over time, and there are some changes. You're higher risk of kind of small genetic mutations in your gametes over time, and that may be part of what's going on. I have to step back too, I think. Shorter birth interval, less than 2 years between two kids, maternal diabetes, and overweight. So something about the intrauterine environment, if there's stress to the parent or nutritional challenges, perhaps that makes a higher risk of autism. And then living near a highway. Any idea why living near a highway would increase your risk? Yeah? Yeah, so maybe exposure to toxins or pollutants, maybe socioeconomic factors, stress, ACEs. You can think of a lot of different things that might be involved. But there's one thing that does not cause autism. Is this a surprise to anybody? How many people get asked to delay or not vaccinate patients? Yeah, all the time. There's no evidence to support it, but when people have a belief, it's really hard to change that belief. And so there's different ways to deal with this, and depending on your own personal practice style, some people just make rules that if you don't vaccinate, you can't come to my program, my practice. Other people try to have some kind of way to work with families over time, and it's really a personal choice. But the best we can do is share information, but also communicate and understand where is the concern coming from, and try to connect with the family and understand their point of view to be able to support them. All right, so once we've made our diagnosis, we also want to conduct an appropriate medical evaluation. And that needs to be individualized, but there are some things we do for all patients who have a diagnosis of autism. Any patient with a language delay needs a hearing evaluation. Even if they had a normal newborn screen, you want to repeat it. Even if they responded to loud noises during your clinical visit, they may have reduced hearing in certain frequencies that are important for speech and language development. Secondly, we want to do a lead test if the child has a lot of mouthing behavior or pica. That's really important to identify. And thirdly, we do recommend diagnostic genetic testing for all patients who have autism spectrum disorder. And right now, the recommendation is for chromosomal microarray and Fragile X DNA testing. Microarray is a technique that it uses probes to identify regions of the genome where there may be microdeletions or missing pieces, or microduplications, extra pieces of DNA. And it helps identify those copy number variants that may be related to causing autism. Most of the panels that are offered through commercial labs will include a range of genetic loci that are associated with either certain genetic syndromes or certain gene functions that are important for brain development and early development and language. In the future, whole exome sequencing may become the test of choice. We're not quite there yet. And Fragile X testing needs to be done because microarray is great at picking up deletions and duplications, but it won't pick up a single base pair change or a sequencing change. So conditions like Fragile X and other other genetic syndromes where there's sequencing changes won't show up. So for other patients, you may want to order additional tests, but it really depends on the patient's presentation. P10 genetic testing is very important for patients who have autism and macrocephaly, large heads. And if in boys, they may show penile macules, little freckles on the penis. And that can be a sign of a collection of genetic syndromes that run together and cause higher risk of hamartomatous tumors. Cowden's, Proteus, these Benayan, Riley, Ruvalcaba are some of the names that have been given to these conditions. And the reason it's important to screen for this is that these patients have higher risks of certain cancers in adulthood. Girls who have significantly more severe phenotypes of regression may have Rett syndrome, so you want to order deletion and sequencing testing for the MECP2 gene. And then other tests may be directed if you're seeing signs of a specific syndrome. Prader-Willi, for example, you often need to do methylation testing to make that diagnosis. What about karyotype? Does anyone order regular old chromosome analysis? The insurance companies are more happy to pay for that because it's less expensive, but it only picks up really big chunks of, big changes, and so it doesn't pick up as many patients as you'll get with the microarray. It is important, however, if you think there's a balanced translocation, because in that case, the individual has all of their DNA and genes, they're just arranged a little differently, so the microarray would be negative in those patients. One flag is if there's a family history of repeated early miscarriages. So if you have some concerns or someone else in the family with a diagnosis, then you might want to consult with a geneticist about which test to order. This slide just lists what you can expect as far as your hit rate. So overall, in patients with autism, our diagnostic testing for genetics is going to be positive in up to 20%, but the rates are higher for patients who have a more severe phenotype, for example, intellectual disability or seizures, and in girls because we're not doing a good job and we're diagnosing only girls with a more severe phenotype. A lot of the other genetic syndromes are positive in about 1% of autism. So, for example, Fragile X is positive in 1% of people with autism, but people with Fragile X, anywhere from 30 to 40% may have autism. And it's similar numbers for tuberous sclerosis. And I've listed the other conditions, maybe 4 to 5% positive rate. And then what about other diagnostic testing? So there was a question early on about should we get an MRI, should we do an EEG? Really, it should be based on the presentation of the child. So we don't do EEG in every child. You will find some mild abnormalities that aren't really treatable in patients with autism, like generalized slowing. But if there's a concern about seizures, staring spells, regression, any kind of really significant concern, then an EEG would be appropriate. MRI is indicated if the child has a very small head, if there's anything focal on your neurologic exam, history of seizures or regression, if your Woods lamp shows concern for tuberous sclerosis, these would all be appropriate indications for getting an MRI. You always have to balance the risk-benefit ratio. A younger child is clearly going to require sedation, and you need to think about what's my likelihood of finding something that I can treat at this point in time. We don't do MRIs if the patient only has macrocephaly. Unless they have some other concern with a focal finding or regression, it's a very low yield, so it's not worth doing. And then metabolic testing is definitely indicated if there are red flags for metabolic disorder. But this is really an area of controversy with different professional groups having different perceptions on what should be done, and it's in part guided by referral biases to different subspecialties. Of course, metabolic specialists feel strongly that we should do the testing in a number of patients because we might identify something treatable that if we treat earlier could really change the child's developmental outcome. On the other side, there's high rates of false positive results, and you end up chasing your tail. for a number of patients, and so there's a lot of controversy on when to order. But certainly if there are red flags like regressions, seizures, not tolerating certain foods, really having decompensation or regression during febrile illnesses, these would all be triggers for making you think about metabolic testing. And this slide is just to remind us why this testing can be so important. And this is actually a case from my own practice. This is a boy that I saw at age 12 for consultation. He already had been diagnosed with autism and anxiety, and he'd had microarray and Fragile X testing that were normal, but his head circumference was huge. It was more than 4 standard deviations above the mean. And when I ordered the testing, it was positive he does have a P10 mutation. Why is that important? Well, he's now being followed by specialists in GI and endocrinology to monitor him over time and make sure that we don't miss any other of the related cancers that can occur. So they need to be tested for colon polyps and then for thyroid cancers over time. There are also higher rates of endometrial cancer and breast cancer. The breast cancer rates are higher even in men, so men need to be screened for that. So in this case, diagnosing a more specific condition and more specialized testing really did inform this patient's medical management. But there are always challenges. You know, who finds it easy to order genetic testing in their patients? Yeah, I certainly don't. There's a high cost. Insurance authorizations are quite variable from one plan to another, from one region to another. And even if your patient's insurance covers testing, they may have such a high deductible that they still get billed for the full cost, and that can be really awful when they get, you know, thousands of dollars in bill. And then the other challenge is that our technology is really proceeding at a pace faster than our knowledge of how to interpret it. So you often get these kind of vague results like a variant of unknown significance. Well, what do I tell a family about that? What does that mean? So that can be challenging as well. And in those cases, I think consulting with a genetics specialist can be helpful to give the family appropriate guidance and counseling. And then there's some controversy about should all girls be tested for Rett? People disagree. Should any girl be tested for Fragile X? Believe it or not, I say yes, but sometimes people say, well, it's a lower rate, but they, you know, the phenotype is so broad, I think you really need to test everybody. And then because individuals with intellectual disability have higher rates, some people feel like it's more valuable to just test those more severe patients, but I don't agree with that either. But all right, so we'll move along now that we've finished our workup to some treatment.
We're going to talk about therapeutic treatment approaches. Right now, there's no known cure for autism spectrum disorder. It is believed to be a treatable condition. We know that these treatments are very expensive, so who is going to provide these treatments? This is information for your reference about the parity law, which was passed to ensure equal coverage of treatment for mental illness and addiction. And here's the website for your reference. You can look up information about this specific law and variations by state. There are 48 states that have specific laws that mandate coverage of ABA or behavioral therapy for children with a medical diagnosis of autism spectrum disorder. For your reference, here's a list of health plans that must follow federal parity. And then here's a list of health plans that do not have to follow federal parity, especially some smaller plans. So just for your own reference, and feel free to look at the website for more detailed information. Research does support comprehensive, individualized, intensive early intervention programs for children with autism spectrum disorder. That's why there's such a big emphasis in early identification and early treatment. Early intervention is often defined as ages 0 to 3. Families will say, my child is 3, does that mean it's too late? And the answer is no, it's not too late. It's good to get intervention at any time. There's just a focus on how much early intervention can help. There's a recommendation for intensive intervention that was originally designed as 25 up to 40 hours. 40 is a lot. It came from the original Lovaas studies. Studies since then have not done as much. The average is around 20 to 25 hours per week, which is more realistic, but this is with combined services, all services. If a child is in school, behavioral therapy, speech and language therapy, but we want to get a child intensive services per week for 1 to 3 years. That's the current definition. And comprehensive, you want to address a full range of life skills. You obviously want to address severe disruptive behavior, but you also want to address communication and increasing social skills and school readiness and self-care. So the number one evidence-based treatment for autism spectrum disorder is ABA, Applied Behavior Analysis Therapy. So what is ABA? It's a behavior approach. It focuses on the principles that explain how learning takes place. How we all learn. Positive reinforcement is an example of one such principle. The old traditional discrete trial models may have had a child point to blue and be rewarded with a cookie. But things have changed. There are lots of different types of ABA, and now people try to link the reward to the behavior. So if a child wants something, then you're working on having them request using a more appropriate communication strategy, such as integrating some eye contact or making a noise or a word approximation or using a gesture and approximation of a point, and then they're rewarded with the item that they want. When a behavior is followed by a reward, the behavior is more likely to be repeated. We all function this way. ABA breaks behaviors down into specific components and works on teaching a specific skill. It's utilized to promote meaningful and positive change in behavior. Part of the pre-learning showed or gave some websites where you can watch video clips of ABA therapy. It's very helpful to watch these clips so that you are very aware of what ABA therapy looks like, and then you can help explain it to families, and so that you're aware about the different types of ABA therapy as well. So ABA therapy, what is applied, what is behavior, what is analysis? Applied means we take what we know about a behavior, we use it to bring about positive change. We apply it. Behaviors, we want to define them in observable and measurable terms. We want to assess change over time, and we need to analyze the behavior within the context. So ABA therapeutic techniques have helped many different kinds of learners acquire many different types of skills. It's been researched and used since the 1960s. Most of the research has been in looking at the effectiveness in treating children with autism spectrum disorder. There's also a growing body of literature showing that it's helpful for people with intellectual disability. And there have been some recent laws that have been passed which say that anyone with Medicaid insurance is required to cover behavioral therapy for anyone who needs it, regardless of diagnosis, which is very helpful. Families always say, who can I go to for ABA therapy? They want a specific referral. It's hard to do that a lot of the time because there's a lot of turnover in therapists, the quality varies widely. We found it more helpful to empower families to understand what to look for in a good ABA program. One thing to look for is that the program supervisor has their board certification in behavioral analysis. They have their BCBA. Oftentimes, a lot of the therapists don't. Their supervisor should. The program should very often provide the family with updates on a child's progress towards specific goals, at minimum every 3 months, often sooner. They should involve caregivers in the therapy and the training. Attendance of the treatment team should be good. There shouldn't be a lot of missed sessions, a lot of changes in the schedule. And another thing to look for, ABA was originally designed to decrease disruptive behavior. So if that behavior is increasing or not getting better, that's a sign that it's not working and something needs to be changed or adjusted. So we mentioned that there are different types of ABA therapy. There's the more discrete trial types and more naturalistic types. There's the Early Start Denver model. It's a relationship-focused developmental model. It uses naturalistic ABA strategies. Psychologists Sally Rogers and Geraldine Dawson developed the Early Start Denver model. It was an early age extension of the Denver model. It can be delivered by therapy teams and or caregivers in groups or in individual therapy sessions in a clinic setting or in a child's home, so it's very flexible. It's relationship focused and it has a lot of caregiver involvement. It was designed for children ages 12 to 48 months. A lot of Early Start programs are receiving training in the Early Start Denver model. PRT, pivotal response treatment. We really like this because it's one of the best studied and validated naturalistic behavioral treatments for autism spectrum disorder. It was started by the Kegels. It really focuses on improving children's motivation during learning and socialization. It focuses on these core pivotal behaviors, which are listed here, including motivation, initiation, self-regulation, and responsiveness to multiple cues. It's thought to be more generalizable because it's not targeting just a specific skill, but a specific pivotal core behavior. It's very child and family centered. It capitalizes on a child's interests and their initiations. It focuses on what they're interested in, and it works on integrating these strategies into daily routines. Social skills training, there's less scientific evidence for specific social skills training programs, but specific parts of these programs are evidence-based. The best evidence is for programs using typical peer models. A lot of people have heard of social thinking, and components of that are evidence-based. Social stories, peer mentoring programs, and video modeling have all been helpful. So oftentimes children that are older or higher functioning do benefit from social skills training.
I'm back. So let's talk about some of the additional services that we can think about for Katie. We're going to start off with Head Start services. And Head Start and Early Head Start, as you I'm sure well know, these are federally funded programs. The idea is really providing a rich learning environment and supporting children's growth in a lot of different areas. Their social and emotional development, their literacy, their language, really working on promoting school readiness. These are truly designed for lower income families, and they emphasize very much the role of the parent as the child's first and foremost teacher, working on building relationships that support the families as well as the child. And many Head Start programs also provide this early Head Start, which is birth to 3. They have to be below the poverty level. These can be home-based, center-based, or a combination of the two. But I send so many referrals for Head Start. I'm sure all of you do as well. And then I want to talk about some of these other additional therapies. We're kind of moving beyond just the behavioral piece now and talking about some of the other therapies that can be helpful for children. First and foremost is the role of physical therapy, helping these children with their gross motor skills. We made mention in Katie's story that she had a little bit of hypotonia. We see many kids who toe walk, who are on the autism spectrum, and there's also kind of a sensory feature to that as well. But really working on toe walking becomes a goal for many people. We may see spasticity because, as you know, we can have a lot of comorbid conditions with autism as well. The next idea is talking about motor planning, and that really is our ability to conceive and plan and carry out a physical act from beginning to end. And some children have significant difficulty with this, and our physical therapists can really help them with that, with their awareness of body and space and their balance and their coordination. Next comes occupational therapy, and we'll talk a little bit more about sensory processing difficulty down the line, but I've always felt that a good occupational therapist is worth their weight in gold, working with them on their fine motor coordination and a lot of those self-care activities and activities of daily living. Occupational therapy can really open up a child's world in terms of feeding, not just the motor movement of getting food to mouth, the fine motor piece, but tolerating different textures and expanding the variety in their diets. They can work with hand-eye coordination, so our visual motor integration. And then they really come in nicely play-based, helping kids initiate and sustain purposeful play. So the role of this, I can't understate. The next thing we'll talk about is the role of speech therapy. And we're going to talk about both verbal and nonverbal communication, and not just their communication skills themselves, but understanding what is coming from other people. So they're going to work with them on their speech and language development. They're going to help with their pragmatic social skills, which is kind of understanding is the verbal and the nonverbal part. We can bring in augmentative communication for the child who truly is having difficulty communicating. The picture exchange communication system, or PECS. Use of technology can really help. I see so many kids who are able to use even their iPads and something nice and portable now. We used to have these big things, Dynavoxes and all that, but now we can go handheld to help augment their communication. And then speech therapy can also work with feeding issues as well. I'm going to pull up my cheat sheet. Some of the specific goals for speech therapy include helping kids learn to articulate well, comprehending the verbal and nonverbal communication, and understanding others' intentions in communication. One sec. You see so often kids come in clinic and their parents will say hello. And the kids are requiring prompting from outside. And speech therapy can work with them on initiating communication on their own, knowing the appropriate time and place to say something like, good morning, or, a lot of these things are by rote, so it's really important that the therapists work with them on that. Developing conversational skills and exchanging ideas. When it comes to speech, it's not just learning to speak, it's learning to communicate. So I did put up some of the components of language production. You've kind of all seen these before and may think or not think about them as much. But we hear many children with that flat tone of voice. We really want to help them with that intonation and improving the rhythm and the flow to their speech. And then we see so many speech issues in autism, obviously not talking at all. Some of them just grunt or cry or shriek. Some of them will hum or talk in a musical way. Some of them babble using more word-like sounds, but nothing that is, meaningful speech. A lot of times, too, they'll make up their own words, or they'll use more something that's a little bit robotic. For some kids, it's a matter of not understanding context. They're entirely too literal. I'm so sorry. I'm trying to scroll down on something, and I'm just gonna read. I had so many things I wanted to convey on this one. They sometimes memorize things without knowing what is being said. They rely on echolalia instead of initiating their own thoughtful speech, and they lack creativity in their language. So it's time for another quiz. We're going to move into a little bit more talking about IEPs and IFSPs. So Katie's family is going to come to you and ask about what's going to happen when she turns 3, because she's getting these lovely birth to 3 services. And you're going to provide guidance based on your knowledge that 1, the individualized family service plan delineates early intervention services from birth to 3. 2, that child is going to transition from an IFSP to an IEP, the individualized education plan, once she turns 3. 3, the IEP provides a roadmap for teachers and staff working with the child, and it holds them all accountable. And then number 4 would be all of the above. So go ahead and use your clickers. Great. So 97% of you said all of the above, and that is the correct answer. An IFSP is, we're running low on battery up here. If we don't plug in, we're going to lose all of our service. I've got a little plug in or find another power source line. Where's the, awesome. What do we got?
It's not pushed in all the way.
It went away. I'm feeling relief. Thank you. So the IFSP transitions into the IEP, and these IEPs are a legal document. This is a contract between what the providers are going to give to the child and the family saying what they're going to give. I now seem to be... There we go. We're going to move it, after all that, we're going to move into another quiz. So the early start program did not help Katie transition in her school district. Oops. So now what are we going to do to counsel the family? The options are: 1, call the school in the neighborhood; 2, complete and request an evaluation in writing from the director of special ed within the school district; 3, share a copy of the DBP evaluation with the school; or 4, would you do 2 and 3? So go ahead and use your clickers, please. We got about 7 seconds left. Okay, so 96% of you said 2 and 3. The more information that the school has in writing, the more you're going to be able, the more the family is going to be able to get from the school district that there's weight to what they're saying, and these are the recommendations coming from the child's provider, and they do need to request that in writing. So preschool IEPs, the IEPs needs will change a little bit as the kid gets older. The preschool IEP, these are all pretty standard. They're going to talk about where the child's present level of performance is. They'll talk about short and long-term goals and objectives for the child, and then describe how they're going to measure that in the child and how are we going to know that they're making progress. It'll thoroughly describe the services and the accommodations. It will say what's going to be done, when it's going to be done, how it will be done, how often they're going to measure it. They will also make a determination as to whether the child qualifies for any extended school year services. And then even in a preschool IEP, they're going to be talking about what will the transition plan be to get that child into kindergarten. The next thing is some things that will be included in the IEP. One, the testing results are going to be there, whether it's the Bailey, whether we use the WPPSI, the WIPSI, we use the preschool language scales, did they use the Peabody developmental motor scales? You'll see combinations of the Peabody for both occupational and physical therapy. The next thing is talking about some of the things that will be used for the child. First example is social stories. So what social stories are is they describe an event or situation with the intent of explaining the circumstances, the perspectives, and what the child's behaviors would be expected to be during that event. These are meant to be very highly individualized for the child, but it helps them understand what an expected behavior is in a given situation. Developing picture schedules can be very, very helpful for children and keep them on task and prevent the meltdowns during transitions. We can give them choice boards where they have a choice between 1 or 2 things. They feel like they have a choice, which is going to limit their meltdowns, but you're also containing it to a few allowable choices. Behavioral charts and reward systems can be really huge for some kids for motivation. And then we will be talking more about some sensory accommodations coming up. And then the next thing that we want to make sure is that there is a behavioral intervention plan, or what a lot of schools call a positive behavioral support plan, to help that child when, to minimize triggers and to what's going to happen if there's an escalation and how it will be handled. So next, just talking a little bit about the Individuals with Disabilities Education Act. And for all of you who are familiar with the newness of this law was spelled out around 1990. What it talks about is once a child enters kindergarten, the IEP, again, It's got to talk about presently where their levels of achievement are. It's going to talk about annual goals and objectives. It will mention what special education services and other treatments will be provided, how there will be how the child will be included with children who do not have their diagnosis, how they're going to participate in statewide and district-wide testing, because that's one thing that can really throw kids off a lot is standardized testing. It'll talk about when the services will start, when changes will begin, how long services will last. It's very specific for that. Again, it's going to mention transition goals and services and how they're going to measure progress. I got to give it a minute to think. What's that? Did I go too far? Excellent. So what are some possibilities in an IEP for the preschooler who has autism? I did go backwards. All right. So in terms of IEPs for the school-age child, goals for communication, goals to get them socially out there, how we're going to help them regulate their behavior in the classroom, how we're going to keep their attention focused, how we're going to help them with their adaptive skills and their academic skills. There are going to be accommodations put in place for transition times, for when the child has increased levels of anxiety, and to help with their attention. The bullying prevention plan is, of course, going to be huge, making sure that these children are monitored for these types of things happening and that there's a solid plan of communication and intervention if needed. Door-to-door transportation may be very essential. Sometimes these kids cannot tolerate being on a school bus with a whole bunch of other children. Next is, will they qualify for extended year services? And then the law does state that you have to start planning for transition when the child is 14. So we start talking about that very young so these kids don't fall between the cracks. The next idea is mainstreaming or inclusion, and this is a topic that's a hot one for families in general. That idea of, do I have my child in a specialty classroom, or do I put them in a specialty school, or am I going to have them included with all of their other classmates, and how are we going to balance that? So the IDEA stipulates that a child has to be in that least restrictive environment with supports from any aides or services. We have to remember that kids with autism may have a lot more anxiety, and they can have a lot more sensory issues in a busy classroom of other children their age, and it may be a little overwhelming for them. So what the ideal is to start the child out by having small increments in an inclusive classroom and let them feel some success, and then build to longer periods where they're increasing their participation in the general education environment. Some families are not as ready for the transition as the children are, and the school and we as their healthcare providers can really be reinforcing and easing them along through this process. And then I wanted to mention some educational accommodations for children with autism. And I don't have to read through all of these, but really having visual schedules and giving them hands-on opportunities and trying to minimize visual clutter and noise clutter. A lot of schools have sensory rooms and offer sensory breaks for children who feel a little too overwhelmed. It lets them gather themselves, get it back together, and then they can go back to the activities. They may need adequate notice for transitions and a clear beginning and end to their tasks. Another thing that schools will often do is let the child, if they're changing classes, transition to the next class before everybody else goes out in the hallways, go crazy between changes for classes. And then we can do all kinds of things to help them be organized, color coding, and doing things visually and providing a lot of support that way as well. So you can read over these, and there definitely are a lot more out there. We were going to take a break, but we wanted to spend just a few minutes trying to catch a couple questions from you. No time?
And And first, I just have a quick pop quiz. Thinking about the DSM-5 criteria, how many different symptom domains do we look at in the area of restrictive and repetitive behaviors? 4. And how many in the area of social communication? 3. Thank you. I was thinking ahead and I said 4, and everyone was very polite and didn't correct me. So we wanted to just make sure that it was clear.
No, we are doing questions.
Okay.
Yeah, we just, both of us had a comment, so
Oh,
we're jumping up.
absolutely.
Yeah.
Oh, go ahead.
So I just had a couple of additional comments related to the IEP process and recommendations. We do have in the references a nice article by Rubel that includes a way to evaluate an IEP of a child who has autism. So it's sort of a checklist to look and see, are all these different areas being met in a little bit more structured way? And it complements nicely all of the recommendations that Beth reviewed in her slides. And then the other thing is, I was interested to see that you put that transition planning at 14. That's true in Massachusetts as well. I think the federal law is 16, and so there are a few states that don't do it till 16.
Oh, wow.
Yeah.
Sooner is better.
I only know that because New Hampshire, which is near me, does 16, and so depending on where my
Okay.
patients come from. We all think 14 is better.
Absolutely. Absolutely. Okay, raise your hands if you have any questions. We'll come around with the microphone.
Work? Yeah.
Yeah.
Okay, so we're going to do 5 minutes of questions. I'm going to go ahead and start in the back, and then I'll come forward. So raise your hand high. Mine is more of a statement than a question that the laws will vary state to state in the way that IEPs are. So in Oregon, IFSPs go through age 5, not through age 3, and that can be tricky for providers, and that children who are age 5, then because they're not in an IEP system, they move from early childhood special ed into kindergarten, presumably. And what's tricky then is we see a number of kids where we think, I don't know that they're quite ready. My experience has been sometimes we're more apt to see districts say, we'll just sort of see how it goes. And so we'll have kids that are in, classrooms with 24 kids or more. And so it can be a little wackadoo. So just people will be aware that it varies from state to state.
Thank you.
I just have a question about some of the research that's showing that androgen exposure prenatally could have an effect with seeing the incidence in boys, one, and also the increased incidence of gender dysphoria in kids with autism.
All right, 2 very different areas, but so the data on androgen exposure is very interesting. I've reviewed a little bit of it, but it's not, it's often in a very different medical literature than what we typically read. But there are some interesting studies looking at whether there's something related to androgen exposure that increases risk of different kinds of developmental conditions. And there is some evidence that supports it. It's not consistent. There have been some interesting studies. So one of the national studies to monitor autism, the SEED study, is a national CDC-funded study, and one of the markers they used as one of their biomarkers was the ratio between the second and fourth fingers. And that ratio is different depending on your prenatal androgen exposure, and they find that men have a higher ratio than women, and people with autism have the higher ratio, so it shows that maleness is a little bit more autistic than femaleness, perhaps, but also supports that there are some complex things going on. It's very hard to study all these things because we can't really do a human experimental model, but it's very interesting. I have no idea whether that relates or doesn't relate in any way to gender dysphoria, but there are a number of studies coming out showing increased rates of either gender dysphoria or questioning gender or having more fluid gender identity in people with autism. And I think, I don't know what's triggering it hormonally or genetically, but I certainly think it fits in with having more difficulty interpreting social information and understanding your own emotions and your own sort of self-identity that a lot of higher functioning adults with autism will describe. So that is an emerging area of investigation as well as intervention. And please, in your histories with your adolescent patients, make sure you are talking about these issues with them, because oftentimes kids are sort of struggling and not sharing their struggles, and you can really provide support for them. There's a question behind you and then one in front. How are we doing? Okay, we'll take two more questions. Last two questions.
The comment was made that once we make a diagnosis of autism, it's a lifelong diagnosis. And yet in some high-functioning autistic children, I've seen a pattern where as preschoolers, early elementary school, they have significant impairment in the social reciprocity and the restricted repertoire of activities. But with appropriate intense intervention by middle school or high school, they may no longer meet impairment criteria. Did we make an originally wrong diagnosis, or can we say that they are now sub-threshold? And can we give parents that hope?
Yes, great question. I knew that was going to come up. You know, it's considered to be a lifelong diagnosis. You're correct, and an article came out that caused a lot of debate, showing up to 10% of children with an early diagnosis of autism spectrum disorder, when they got older, they were found to not meet diagnostic criteria anymore. It's hard to know, were they misdiagnosed in the first place? We do know that symptoms do change over time and with the course of treatment. I'm hesitant to tell families that many children do outgrow this, because the majority of children don't. It does tend to be a lifelong diagnosis, but we do know that the presentations vary dramatically. So I do like to say that, some children, it is a big spectrum. Focus on that child, talk about that child. If that child is high functioning and does have a lot of strengths, you can talk about that. The two best indicators of a good prognosis, or the two signs that a child will do well in the future, are use of language around age 5 or 6 and intact cognitive functioning. So if a child has those things, then you can instill hope and you can talk about where the child is at right there. We really try to talk about goals for the child in the immediate future. None of us have a crystal ball. None of us can predict how a child will end up ultimately. Families worry, and they will ask about that. They will say, can my child live independently? Can my child have a job? Can my child cultivate relationships? And you can say there are a lot of people with autism spectrum disorder that do all of those things, and their symptoms have minimized or don't interfere with their functioning, and they're not even noticeable to people anymore. But I think that you have to be very careful about what you say when you're giving that diagnosis.
I'm wondering if there are guidelines, or if you think it's worthwhile to send for a genetic workup if a kid had negative initial screening, but then a few years later you're wondering maybe tests are more sensitive. So if you're resending kids, if that's practice.
So I'm going to start out, I'll start this question up because I just saw this in my clinic this past week with an 11-year-old boy. He had some genetic testing done and was seen by genetics when he was about 5 at diagnosis. We sent him back last year. We said, we'd really like you to go back and see, because this is a family who has sought deeply for answers. And we actually found a mutation in the PLXN1 gene, which is X-linked. It's associated with, with autism and intellectual disability, which is very much his presentation. And his family has come back, and they are thrilled that they went back because they're seeking and it helped them. Obviously, when we send out to genetics, it's now genetics' job to make the case for getting the testing, and they always have all the resources to do it. They're really good at it. But it had been a number of years, and sometimes it does make sense to say, why don't we go back and revisit, because we know more than we used to know. So I think that it's appropriate to send them back, because you may be able to answer something or lay something to rest a little bit for a seeking family. Anything to add?
No.
Okay. All right. And we have so much we want to tell you in that last hour, so come back. Come back, please.